Okay, morning everybody. Thanks for being with us. I'm Matt Gerlach, one of the spine surgeons at OCR. I'm going to talk to you guys a little bit about cervical disc replacement versus the traditional cervical fusion. Disclosures. So I won't torture you with an anatomy lesson, but just to give you guys some baseline, our spine anatomically is put together, made up of numerous structures. You see here the numerous bones that make up our spine, the cervical spine being the uppermost section. The numerous muscles within our neck and upper back. And then the all-important nerves and spinal cord that run through the center core of our cervical spine. And at each level through the cervical spine, there are individual nerves that branch off the spinal cord and travel into our arms. Just to touch on neck pain, it's not a surprise that neck pain is a very common problem. Given all those anatomic structures, it's a very common problem, roughly 2/3 lifetime prevalence, 10% at any point in time of adults are struggling with neck pain. One of the big challenges in the area of neck pain is what exactly is causing your neck pain. And again, if you look at this slide, that picture, the numerous structures we have in our cervical spine, and this applies to your spine, lower back and mid back as well, but we have all these cartilage discs, cartilage joints, bones, ligaments, muscles, nerves, and these structures are all integrated in this, fantastic fashion, but nonetheless, all of these structures individually or in combination are potential pain sources. So any given case of neck pain, in most cases, see what I've put at the bottom, in most cases it is exceedingly difficult to know precisely what's causing someone's neck pain, which leads to the difficulty in treating neck pain. The good news is short term, the majority of individuals having an episode of neck pain, 80 to 90% of those patients are going to be better by 3 months. Long term, individuals that still are having some aspect of neck pain, roughly speaking, long term, 50% of patients become asymptomatic. There's 25% of those that they'll continue to have their intermittent episodes, and then the unfortunate 25% of that long-term crew are going to be moderately disabled from their pain. What can be done for neck pain? Well, from my perspective, from a surgical perspective, the vast majority of cases of neck pain, surgery is unfortunately not a good solution. And neck pain is really managed primarily with the combination of non-surgical treatments, physical therapy, chiropractic treatment, massage, acupuncture, sometimes interventional spine injections can be effective, but that's really the gamut of things that can be experimented with. I often use the word experimented with patients because really it's one big experiment when you're treating neck pain. So that's kind of an intro. Moving into the surgical side of problems in the neck that might be dealt with successfully with surgery. When is surgery a good option? Primarily, it's when you're dealing with either a nerve or spinal cord being pinched or compressed by something in your neck. Cervical radiculopathy, many of you may have heard of this term, but it refers to a condition when a nerve within your cervical spine is compressed or pinched by either a cartilage disc, protruded or ruptured, or a bone spur. So that picture, let me go back. That picture on the left is just showing, these are bird's eye views of your cervical spine, and here you have disc, here you have spinal cord, and on the left and the right are the nerves that branch off the spinal cord. And this picture on the left is giving a demonstration or a picture of a bone spur that has formed off of this joint that's pushing into this nerve, and that's a very common cause for someone having shooting pain down their arm. The picture on the right, instead of a bone spur, here you see a picture of, here's disc, Spinal cord is this yellow structure. It's not really yellow, but it's this yellow structure. And then again, nerve branch that's come off the spinal cord, and this disc has torn, and you see the chunk of that disc that's protruding out, pushing into nerve. That's the other very common source of these are really the two major sources of nerves getting pinched or spinal cord getting pinched in our cervical spine. The symptoms, what sort of symptoms does someone have with radiculopathy? Again, a pinched nerve in your neck. Well, the most common is pain shooting down the arm. And usually, so our nerves take a very predictable path down our arms, and typically a patient will feel a pain traveling down their arm into various aspects depending upon what nerve is pinched. Other symptoms, though, what do nerves do? They provide sensation, they are basically the wiring to our muscles and allowing our muscles to work. So if a nerve is pinched and injured, anything that nerve does might not be working correctly. So a patient might feel burning, numbness, tingling, weakness to the specific muscles that nerve helps to operate. And then oftentimes it also worsens a person's neck movements. Cervical myelopathy is different from radiculopathy. Myelopathy stands for disease of your spinal cord. In simple terms, it means something causing pinching of the spinal cord. And here on this picture, you see again an example of disc that has ruptured, and that ruptured part of disc is pushing into the spinal cord. Another very common source of impingement or compression to a spinal cord is the normal aging process that takes place to the discs in our necks. Oftentimes, as a disc wears down, bone spurs will start to form around the margins of that disc, and as those bone spurs get larger with time, they take up a lot of space. And at some point in time, that space, especially around your spinal cord or the adjacent nerves, gets narrower and narrower, and that narrowing is referred to as stenosis. And if that stenosis gets severe enough, it can start to affect the function of either that spinal cord or nerve. Myelopathy, as compared to radiculopathy, is definitely a more serious problem because you're dealing with your spinal cord rather than an individual nerve. If left untreated, there's a significantly higher risk of permanent damage to a person's spinal cord. The worst case scenario, often overly used, but the term paralysis is often thrown out. Fortunately, that is not something that happens at a high rate at all, but nonetheless, if someone takes a bad fall and they have severe stenosis in their neck, already causing pre-existing compression of their spinal cord, that's kind of like the perfect storm, that someone can all of a sudden have severe injury to their spinal cord. Myelopathy symptoms, oftentimes, this is what makes myelopathy somewhat tricky. It tends to occur in the older generations, 60s, 70s, 80s. And in that age category, if you look at some of these symptoms that are classic or characteristic for myelopathy, some of these symptoms are often initially attributed to, well, I'm just getting older, these are just typical things. But numbness and tingling in the hands, weakness in the upper extremities in particular, and more so in the hands, loss of dexterity, and again, this is another one that comes with a challenge of, is this just me getting older or do I have a problem? But trouble manipulating buttons, dropping cups, coins, objects, handwriting can change. And again, many of you might say, well, geez, my mom and dad, my dad's 76 and his handwriting is markedly different than it used to be, and he doesn't have stenosis or myelopathy. But nonetheless, these are all kind of a list of questions to look out for and ask patients, and if they start checking boxes of, yeah, I got that. For instance, when I see patients and they're primarily seeing me for a back problem, I often will ask them some of these questions because if they start telling me yes to many of these, I get suspicious that they might have a problem in their neck as well. And I don't have a slide here, but just to roughly about 80% of individuals, if they have significant arthritis in their lower back, they're going to also have significant arthritis referring to just the normal aging, wearing, and tearing of discs and joints in your neck. But 80% of those individuals will have similar arthritis in their neck, and if they have arthritis in their neck, there is definitely a distinct chance that they may be developing stenosis and this myelopathy problem. Hence why asking these questions is kind of a routine part of our evaluation of any patient. Other problems that are classic for myelopathy: trouble walking or difficult with your balance. Way less common is loss of bladder control. If I hear that, that's a very atypical presentation, and something else is wrong. But the trouble walking and poor balance, that, however, is very common, and that also is a challenge to tease out: is this normal for age? For instance, if I'm seeing someone 77 years young, and they tell me they're seeing me again for their lower back primarily, and they tell me part of their problem is they're having difficulty walking around and their balance isn't what it used to be, and their spouse says, yeah, my husband looks like he's drunk when he's walking and it's only noon. So these are all questions and problems to look out for. So when it comes to surgery on the cervical spine, there are several different options. I'm only touching on two today, and definitely the two that I'm touching on are the most popular and most successful. But what are the goals of surgery? The goals essentially are, as I point to here, taking pressure off either the pinched nerve or the pinched spinal cord. And then in doing that, it usually involves removing whatever structure is pressing on your spinal cord. Typically, you have to then do something else to make sure the bones that the disc or bone spur are attached to are going to be stable after you've removed that structure that's pinching nerve or spinal cord. Good communication with your surgeon to really understand the options and for your given condition. So the two most common and successful surgical options in the cervical spine: the top one, anterior cervical discectomy and fusion, short for ACDF. That's by far and away the kind of the gold standard. It's been around for nearly 70 years. It's the surgery that most people are likely most familiar with. And then the one I'm highlighting today, in comparison to fusion, is anterior discectomy, followed by replacing the disc with a synthetic disc replacement. ADR is commonly what it's referred to. And again, these are the most common and successful surgical options in the cervical spine. Anterior cervical discectomy and fusion involves removing the damaged disc that's herniated or ruptured, that's pressing on nerve or spinal cord, and then into that empty space between the two bones, you restore the position and the alignment of the bones, and then into that space, you put a wedge of bone, or sometimes there's also a device called a cage that serves the same purpose. It fills that space, and the inside of the cage is filled with ground up bone. And then you additionally insert a thin plate attached to these bones with screws. And the plate and screws simply serve as a clamp, holding the bones together, so that over time, the intended result here is that this bone that's placed between the two vertebrae will grow solid to those two bones, permanently growing the two vertebrae together. And really, for decades, this surgery has been the gold standard. It was first at least written literature papers in regards to describing the ACDF is 1955, 1958. So as you can see, it's been around for a long, long time, and it has had some of the highest success rates across spine surgery: cervical spine, lumbar spine, thoracic spine, you name it. It's one of the most successful spine surgeries invented and still done today. ACDF has an 80 to 90% success rate. Usually there's roughly a 6 to 9 month recovery period. Use of brace for a short period after surgery is typically done, although that's somewhat controversial and varies from surgeon to surgeon. The rate of that bone that growing together solid, well, the rate of it not successfully growing together solid is about 5 to 15%, which is referred to as a non-union. And that percentage is much higher in smokers, 30 to 40% in smokers. So it's a big deal in nicotine users. And then this bottom line is one of, as you'll see in additional slides, this bottom slide is really what it is probably the biggest concern that surrounds ACDFs, concern for adjacent segment disease. What does adjacent segment disease mean? It means it's what's going to happen to the neighboring discs in your neck if you have a fusion. And will that fusion create an increased amount of stress transmitted to those neighboring segments, and that extra stress, will that eventually lead to those neighboring discs wearing down faster than they naturally would have? And then, so artificial disc replacement. What you see here is one of the current contemporary most popular devices, and what you're looking at here is essentially a mini knee replacement. What you've got here is two metal plates, one on top, one on bottom, and then in between those two metal plates is a very fancy piece of plastic that's tied in, that's secured between those two plates. And you can see here that device has been put into two cleared out disc spaces, and these disc replacements, well, they are a mobile bearing little small joint, and they allow motion to continue at that segment where you insert it. And then the surface coating of these little metal plates grows, the bone, the vertebra actually grows into the surface of these metal plates. So after several weeks, those metal plates are rigidly grown to the vertebra that you've inserted them in between. So I should point out the operations, the first part of both a disc replacement and a disc fusion, the first part of the operation is exactly the same. You remove the damaged disc. The difference between the two operations, probably obvious, but the difference is what you're putting back into that space. Either you're welding the bones together and you're eliminating the movement between those bones, or you're putting one of these devices in and you're preserving some motion between those bones. Disc replacements, they've also been around actually quite a long time. 1991 was one of the first devices invented in Europe. They've been in play and used in Europe for far longer than in the United States. The first US FDA approval was in 2007. But really, cervical disc replacements have become more mainstream, I would say, in the last 5 to 10 years and in the United States. And a lot of that has to do with insurance approval for these surgeries. Prior to the last 5 to 10 years, unfortunately, most of the commercial insurance companies would not authorize or pay for cervical disc replacements. And that's a whole separate talk. But nonetheless, that's why in the past 5 to 10 years, myself and many of my colleagues, these cervical disc replacement surgeries have become really a more relevant and real-time option that I can bring up to patients, because not a lot of normal human beings can afford to pay for these surgeries out of their pocket. So what's the whole discussion between an artificial disc replacement versus a fusion? Why would you do one versus the other? Well, the discussion does not center around the success rate of the two operations. The success rate of both operations has been clearly shown in endless numbers of studies. Is roughly, like I mentioned, 80 to 90% of patients will have relief of their either radiating pain or their myelopathy symptoms. The discussion centers around the three variables that I put up in this slide. Number 1, range of motion. Number 2, adjacent segment disease. And then number 3, cost effectiveness. disc replacement ADR aims to maintain the physiologic range of motion at the operative or index level, and then hopefully reduce the motion and stress that you're transmitting to the neighboring segments. And as I mentioned before, hopefully if you're reducing the motion and stress to those adjacent segments, it will lead to less degenerative disease at one or both of those adjacent segments than the natural history of that disc would play out. Again, adjacent segment disease is technically defined by symptomatic radiculopathy and or myelopathy adjacent to a previous successful fusion that's severe enough to warrant management. Now, management doesn't necessarily mean surgery. Management might mean someone comes in, 5 years ago they had a fusion and now they've got shooting pain down their arm again. And management might be, well, you never jump right to surgery anyway. Management often is physical therapy, a cortisone steroid injection, chiropractic treatment. I should note that for cervical radiculopathy, myelopathy is a different story, but for radiculopathy, roughly 70 to 80% of patients going through an episode of radiculopathy will successfully resolve that episode with non-surgical options. So surgery isn't, by far and away, is not an automatic for someone having a radiculopathy episode. So in these folks that have recurrent problems, a large percentage of them are not going to end up having a second surgery. But nonetheless, the definition is, as said above, and that 2.9%, 3%, is roughly the number that has been quoted in numerous papers, but 3% per year after cervical fusion. Someone will have an adjacent segment that is diseased enough to cause them to have radiculopathy or myelopathy. So, 3%, you multiply that out over years, 30% of folks are going to have issues 10 years after their initial cervical fusion. So that's really the bugaboo between, fusions and what are the downsides to a fusion, and can a disc replacement improve on that number? And in comparison, multiple studies have been done over the past 10 to 15 years and have clearly shown ADR compared to fusion. Many of the studies in these comparisons that are generally thought of as the most high quality and reliable are studies that have 5 to 7 year follow-up. And what these studies have shown is roughly ADR, about 3 to 6% of those had revision surgery at an adjacent level as compared to 11 to 14% for a fusion. So roughly ADR is revision surgery after ADR is roughly half of what it is for cervical fusion. So that's a significant number, obviously. Are artificial disc replacements an option for everybody? And the answer is very quickly no. An artificial disc replacement as compared to a fusion definitely has significant or a substantial amount of extra variables that have to be in place for it to be a good option. And as I listed here, contraindications, if there are 3 or more discs that are all contributing to the problem. In the United States, at least, a cervical disc replacement at 3 levels or more is not an option. Currently, the FDA has only approved for 2-level disc replacement in the cervical spine. 3 or more levels certainly is done elsewhere. It is not an uncommon occurrence for United States residents to go to Europe and have some of these disc replacement surgeries at multiple levels done. I've seen several of these patients back for follow-up after these things have been done. But additional contraindications, if there's any instability between the bones, a disc replacement can't be done or shouldn't be done. And the reason it shouldn't be done is if there's instability, that indicates that something is wrong with the spinal facet joints at that segment in the person's neck. And if you put a disc replacement in a segment where there are unstable facet joints, oftentimes, guess what will happen? The disc replacement will continue to be unstable, and that's a bad situation that you want to avoid. Other contraindications, if patient has a deformity in their neck, especially kyphosis, the normal, at least the most common, alignment of our cervical spine is the opposite of kyphosis. It's called lordosis. And if someone either naturally or because of degenerative disease has a kyphosis deformity, once again, a disc replacement is thought contraindicated because of the instability that often will develop with that device because of the deformity. Metal allergy is another contraindication. Most of these current disc replacement devices, the metal plates that I showed you, most of those are a cobalt chrome. And for human beings that have metal allergies, cobalt chrome often is in that list of what they're allergic to, as compared to titanium, for instance, is a much less common allergy and when someone has a metal allergy. Previous surgery at the same level, vertebral body deformities, facet joint arthritis, which, as I mentioned, facet joint arthritis plays into the segmental instability problem. If someone's disc is severely worn away, if it's almost completely worn away, a disc replacement tends to be a less ideal option in that situation because, interestingly enough, when you take the disc out, put a disc replacement device into that severely worn down disc space, a high percentage of those individuals will actually create a fusion across that disc replacement device anyway. And you're just better off doing a fusion in that situation as compared to a disc replacement. And then lastly, osteoporosis is thought of as a contraindication. You guys, most of you in the room probably know who this guy is. Peyton Manning became a Bronco in large part because he had a cervical fusion. So Peyton Manning had a herniated disc, and which caused him to have radiculopathy, and he had weakness in his triceps muscle, which is difficult to throw a football with triceps weakness. And he was an Indianapolis Colt at the time, and he had 2 smaller surgeries in hopes of being able to continue playing that football season. Ultimately, those did not work. I didn't highlight what that particular surgery is today, but it didn't work in his case and doesn't work in a lot of individuals' cases. But ultimately, he had a cervical fusion, and because of that, generally speaking, a cervical fusion, especially for athletes and especially contact athletics, typically you're out of that sport for a minimum of 6 to 9 months after a fusion. So for Peyton Manning, that meant the end of that season, and as many of you know the story, the Indianapolis Colts decided to draft Andrew Luck and say goodbye to Peyton Manning, and he became a Bronco because of that, and you know the rest of the story. Had he had a disc replacement, probably would not have been a Bronco. And then these guys are 2 of the most recent, 2 current NHL hockey players. The guy on the right, Jack Eichel, is the first to undergo a cervical disc replacement in the NHL. And this Tyler Johnson on the left is a Blackhawk. Both of these guys had radiculopathy, herniated discs, and rather than undergo a fusion, each of these athletes underwent a disc replacement and were successfully back to playing NHL hockey 3 months after the surgery. So this has kind of been a big deal in the professional athlete era. As to date, there's been no NHL or NFL active athlete that's undergone a disc replacement. There's been plenty that undergo cervical fusion. If someone has a herniated disc causing radiculopathy or myelopathy in a professional athlete, just use the NFL as an example, they get a cervical fusion. Problem, as I mentioned, is that means 6 to 9 months you're out for that season. And I won't bore you with all the studies, but a significant number of those athletes actually never get back to playing again. And Jack Eichel is kind of, ADR has been somewhat joked among spine surgeons. It might become the Jack Eichel surgery. You've heard of the Tommy John surgery, many of you, but the Jack Eichel surgery, because it's such a change from the norm. And Jack Eichel actually had a herniated disc. He played for the Buffalo Sabres at the current time. The Buffalo Sabres said no to a disc replacement. Eichel actually did his own research on his own and strongly wished to have a disc replacement, and the Buffalo Sabres said, no, we're not doing that. That's never been done. Long story short is Eichel fought for this and ultimately was traded to the Vegas Knights, and the Vegas Knights allowed him to have a disc replacement 8 days after he was traded, and 3 months later he was playing against the Colorado Avalanche in 2022. So important questions for you to ask, for a patient to ask, if they have one of these problems: will I have permanent damage if I delay surgery? The good news is for the vast majority of patients, the answer is no. It's never 0% chance, but the good news is no. Are there non-surgical alternatives? Absolutely yes. As I mentioned, the first-line treatment for radiculopathy in particular is physical therapy, spinal steroid injections, chiropractic treatment, massage therapy, acupuncture. These have all been shown to be effective in a large percentage of patients. Will I need a fusion? Are there non-fusion alternatives? And as I've presented today, obviously there definitely is a non-fusion alternative now for a large percentage of these patients that fail non-surgical treatment. What are the risks of surgery? Does surgeon use spinal cord and nerve monitoring? How successful is surgery? How does surgeon define success? That's always a good question. Does surgeon define success by looking at the x-ray and saying, wow, look at how well placed that device is, even though the patient is still complaining of pain down their arm? Can I return to work? When can I return to work? When can I return to sports? How long will the surgeon continue to follow me for checkups? As I mentioned, for the most part, a cervical disc replacement, return to full activity is 3 months after surgery. And for a fusion, it's a little trickier. It's generally 6 to 9 months, but really it's defined as whenever that fusion is solid. Typically that's when a person is allowed to go back to unrestricted either sport or, if it's manual labor, full activity at work. So summary, ACDF fusion and ADR disc replacement both have high success rates for 1 to 2 disc level surgery. The pros or advantages to ADR, equal or superior results to a fusion, shorter recovery time for sure, allows for full return to either work or sport activities at a shorter point in time, lower rates of adjacent segment disease, and as a result, lower rates of revision surgery. The cons to an ADR, there's definitely far more contraindications to when you can successfully put one of these devices in as compared to a fusion. And then there's still, as far as the complications and the longevity, how long will one of these things last before it wears out? The longevity of some of these devices still needs longer term follow-up, like 10 to 20 plus years. And that's all she wrote. Thank you much.